Hey guys, thanks for turning into Straight to the Core, an in-depth, no-nonsense look into all things physical therapy, wellness, and the business of being healthy. We are your hosts. I'm Claire. I'm Mark's wife.
And I'm Mark. I'm Claire's husband.
Today we are talking about, again, ACL Part 2. Yes. All of the rehab considerations.
Rehab.
Yes.
All right.
You've torn your ACL.
And you had surgery.
Yes.
What do you do?
You went through prehab and you did the whole thing, and now you have successfully survived surgery.
Important note.
Please.
If you're having your ACL done and you're going to find a rehab specialist, make sure they do this for a living. Don't get a person who dabbles in it.
Right.
There's a lot of dabblers out there. You don't want a dabbler. You want somebody who does a lot of this. Somebody
who is really invested in you getting better and not just someone who is taking your money.
Yes, and if you're going to do rehab on an ACL and there's no weights, no machines.
We'll get there.
Yeah.
Wrong
place.
Calm down. If you listened to part 1, which I hope you did, because otherwise this one's going to seem like it bounces around a little bit. We talked about surgeon shopping and finding a surgeon who does this all the time, who is invested in, you having the best outcome. It's okay to PT shop as well. If you have somebody that you're like, oh, hey, like I've seen this person off and on for little aches and pains, but they're not somebody who sees ACLs a ton. So not a bash by any means on some of the cash pay people, but obviously, ACL rehab is a post-surgical rehab, and cash-based business just tends to not see a lot of post-op patients because you've already met your deductible, you've used your insurance. So why are you continuing to pay for something that your insurance is going to cover? However, that doesn't mean that all insurance-based PTs know what they're talking about, know what they're doing with ACL. So long story short, shop around. It might be somebody who is different than what you've used before. You need to find somebody who does this.
Yes, and your therapist with 10 years of experience might have spent 8 of those in a nursing home, okay? They're not ready for that.
Right.
This is a complicated rehab. I know it's common in relative terms, but it is very, very complicated from a mechanical, biomechanical, and a loading phase stage.
If you are not familiar, so Mark and I own C.O.R.E Physical Therapy in Omaha, Nebraska, and we're an orthopedic outpatient clinic, but we do specialize in sports and athletes. And I think it's awesome that this happens, but it's also really frustrating is that when we say that we specialize in sports and active individuals and athletes, sometimes people come to us after they've done their primary rehab someplace else, and they're like, well, I didn't realize that I wasn't going to get back to playing sports or going to the gym or playing with my kids because the kind of generalized PT that they had seen for their rehab didn't really know how to progress them or couldn't go any further than, we've got you off crutches, we've got you moving around, you can live your life. And so I think it's very cool that people come to us to say like, hey, I know I need more help, and like you guys are the specialists with this. But it's also really frustrating that
you're inheriting a problem now too, so you have to fix a mistake and then rebuild on that. That's hard.
We'll get there though. This one might be a little more ranty than the first.
This is going to be actually.
The first one was a little more research heavy, and we sounded all professional. This one's going to be very informative, but we're also probably going to trash talk some people as well.
Yeah, probably. Another side note, one more. Same thing, because I'm going to get ranty here. If you're a physical therapist and you aren't good at rehabbing an ACL, realize this and don't do it or get better or figure it out.
Yeah. You
should know whether you're not. If you don't see them, send them to somebody who sees them.
Yeah.
Don't just wing it. Somebody's career could be on the line.
Yeah.
A sports career. Yeah.
Absolutely. Okay, so you've had surgery. Post-op. Day 1, day 2, we usually see people now.
Yeah.
You're going to start PT. You're going to start PT early because motion is lotion, man.
Yeah, motion.
We're getting things moving. Now, there are a ton of post-op considerations that are specific to what surgeon you use and what the surgeon's protocol is. So sometimes we see people braced, sometimes we don't. Sometimes people are locked in extension, sometimes they're not. Sometimes they're partial weight bearing, sometimes they're full weight bearing, sometimes they're on crutches, sometimes they're not. There's a wide variety, yes.
And it also depends on what other surgeries happened during your surgery. ACL isolated or meniscus involvement or something else.
Partial meniscectomy where they cleaned it up. Was there a meniscus repair, in which case you might be non-weight bearing for a while, or partial weight bearing,
Correct,
or you might be locked in an extension brace while you're weight bearing. And all of those things, if you have a good surgeon surgeon, if you have a good PT, all of those things are going to be explained to you. And not that necessarily you should know going into surgery what's going to happen, because sometimes you get in there and the surgeon's like, whoa, we got to repair that. This is, I told you maybe you were going to be walking after about a week. Now you're going to be partial weight bearing or non-weight bearing for 4 to 6 weeks, which is usually what happens with meniscus repair. It can happen in isolation as well, but it happens commonly with an ACL.
It's a real gut punch if you go in thinking it's an ACL only and you come out in crutches and you're non-weight bearing 4 to 6 weeks and they're like, what happened? Well, sometimes when they go in there, they see more. It's kind of like when you renovate your bathroom.
Yeah.
And you're
you're just moving a toilet, and then all of a sudden you go to replace the wax ring and you're like, oh, there's
the whole floor needs to be replaced.
So that's an excellent example, Mark. Nicely done. But I do think it's important to note that even though initially sometimes those things that aren't expected will slow down the initial progression of your protocol, you end up at the same spot, right? So yes, you can have 2 ACLs and one is an ACL in isolation, or one is an ACL with maybe a partial meniscectomy where they're just cleaning up a meniscus tear, compared to an ACL with a meniscus repair. If you're comparing those two, you might have the meniscus repair be like, oh man, I am so far behind. I'm still on crutches. I'm 4 weeks out. Why is this person next to me off crutches, walking around? Like, it's hard to tell that they even had surgery. 2 completely different surgeries, 2 completely different factors. However, they will end up at the exact same spot if you do rehab well. Yeah.
I'm going to break usually down in 4 phases / 5 phases. I'm going to say early range of motion strengthening phase. You got a pre-run phase. You got a run phase with plyos, return to sports phase number 4. And then sometimes you got a heavy return to sports phase with heavy contact simulation. So that might be the 5th one if you are playing sports that involve those type of things.
I'd say, similar. I think mentally, and how I'll explain it to patients, is that initial range of motion, just get you back to living your life, ADL phase, probably first 4 weeks, I would say. Then you have the heavy strengthening phase. So from 4 weeks to about 10 to 12 weeks. Then where it's all about strength, it's all about balance, it's all about,
and letting the graft continue to heal and revascularize. Even though you will feel fantastic at 10 to 12 weeks, you are not.
Yes. Well, at 4 weeks, a lot of times too. Then you have your plyometric phase and your running phase where you're trying to, all planned movements. Hey, we're jumping. Hey, we're running. Then you have your lateral movement / agility phase. And then to me, it's that like heavy hitting, return to sport, reactionary.
Which is one of Claire's favorite phases when she introduces contact and falling.
I get to push them down.
I introduce, fouling and different sports. You have to get fouls. You have to get contact. You have to get hit on the jump and the landing. Awkward landings, very important. You have to do contact sim.
Now, I will say this is a broad generalization, but if you do it, you will. If you know, you know. That's a general protocol, right? What will separate a really good physical therapist and a really good rehab from just a subpar is, 2, maybe 3 factors, even though the third one kind of ties into the first 2. Number 1, how did the ACL tear happen? And I think so many people forget that factor, and it drives me insane. If you are a female athlete that tore their ACL in a non-contact way, guess what? There's going to be so much single limb control in your rehab if you're my patient that, yes, general strength is important. Yes, I want you to squat and lunge and leg press and deadlift and all of those things. But if you tore your ACL because you planted and cut and had a non-contact ACL tear, that's the number one thing I'm looking at.
Yes, and strength alone will not protect the ACL. You have to know how to use the strength. You have to use the balance and the proprioceptive awareness to prevent that.
And then the second thing that will change your protocol is, what are you going back to?
Correct.
So, and then the third thing that goes into the first 2 is just basically, what are the deficits that you've identified in that patient?
Yes.
Protocols are great, but it drives me insane when people will say like, well, I need a protocol for this equestrian jockey that tore their ACL and wants to get back. There is no protocol that exists for that, okay? You have to figure out what your athlete or what your person does in that sport or does for a living that they need to get back to, and then what are the deficits that exist? I'm getting ranty already. What are the deficits that exist that you need to correct?
Yes, it depends. What do you look like? What's your movement quality? What's your strength? And how mechanically aligned, how aligned are you?
I do love it when patients come with a protocol, because a lot of times it's like, oh, okay, yeah, like what was that specific surgeon's range of motion restrictions? It might be completely different than a different range of or a different surgeon. There are some surgeons, like I said, that will do partial weight bearing with meniscus. There's some surgeons that do absolute non-weight bearing with meniscus, and that's all fine. That's great. Protocols exist for a reason. But when people only stick to the protocol, and for the first 4 weeks of an ACL rehab, they're just doing straight leg raises and recumbent bike because that's what the surgeon protocol said, it drives me insane.
Yeah.
Insane.
Yes.
If that's what you're doing, then
and so
do better.
If
Figure it
your
out.
protocol says, oh, run at 10 weeks or run at 12 or 3 months, you might be ready, but you might not be ready.
Right.
If your movement quality isn't there and your strength isn't there, you're not running until you're ready.
Right.
So those are just guidelines, but they're not set in stone.
There's a handful of surgeons, like 3 or 4 surgeons here in town that we have. Well, we have really good relationships with a lot of surgeons, but 3 or 4 that I will literally text or call and say, hey, so-and-so isn't where I want them to, then we're not running it, especially if they have a follow-up coming back. A lot of times patients will go in and they'll be like, well, my doctor says that I can run at 12 weeks. Well, yeah, let's hope so. Like, let's do everything in that first 11 weeks to make it so that you can run at 12 weeks. But if you look like absolute poo at 12 weeks, like, I'm not letting you run.
Just because you can run doesn't mean you should run.
Right.
Yeah. So.
Okay. So yeah, that first 4 weeks, whether you are, partial weight bearing, meniscus, ACL, isolation, our main goal is to get that range of motion back and for you to live your life.
And get that quad firing.
Yeah.
It's not uncommon to be lifting your leg.
Lift your own leg.
And you're like, oh my God, my leg doesn't work. Well, that's pretty normal. Sometimes it can take a couple weeks to get that quad to fire back. Your body is trying to protect you. It doesn't know that it had surgery. It thinks it just got, bashed in a car accident.
Right. Now, if you listen to part 1, we talked about graft types. And so if you had a hamstring graft, the weird little caveat about your first 4 weeks of rehab is that we don't do anything hamstring related. We let that sucker kind of scar down.
Yeah, we need to. So no hamstring strengthening generally for at least 4 to 6. And it's pain dominant related too. So if they're still having a lot of pain at 6 weeks, we got to figure that out. And we can't strengthen through pain. That's a terrible idea generally.
Right. And if you know me, well, and Mark as well, you know that we love cats. Where am I going with this? You might think. There's 900 ways to skin a cat. I don't like that saying, but it's very common. There are 900 plus ways to get range of motion back in a knee. And there's not one way that's better than the other.
It depends.
Yes. And I say that because there are some people who are like, oh gosh, it just hurts so much when, you're passively stretching my knee. That's fine. Then guess what? We won't do passive stretching. We'll figure out a way for you to be in control of that motion.
There's many different positions.
Put people on the shuttle or the leg press. You put people on a recumbent bike. You have people do heel slides. You have people completely in charge of their own range of motion. It also drives me crazy. I guess this is just going to be a topic that drives me insane with some subpar PTs. But not every bit of range of motion needs to happen because I'm in control of it. There's plenty of time. I mean, that's an injured part of their body. Yeah. Of course, people are going to be a little hesitant and guard with it. And that's totally fine. What is important is that you eventually get that range of motion. And once people get that range of motion and they think, oh, okay, yes, I can relax into this. I know it's not going to hurt. Then we hit passively.
Yes. And I would say that by and large, for most people that I work with, I rarely have to put extra pressure on them because if you introduce the right amount of motion in the right ways, at the right times, in the right intensity levels, I shouldn't be having to do a lot of external forcing of it.
I would agree.
You have to. Timing is important. Quality is important,
especially with extension.
Correct.
I think too is that people need to be able to relax into extension.
Early extension.
I do have a handful of patients that I know that passively or when they relax, they can get new extension, and then for some reason they just don't actively like to keep their knee in that position. Yeah. But
I do have, when you have a hamstring graft, it is harder to get extension because they don't tolerate prone hangs very well.
Right. Or that hyperextension position.
Yeah, they don't like that because it hurts.
Yeah. But the big no, don't put a pillow under your knee if you happen to be listening to us.
Well, you can, but put it under your heel like 3 times more often.
Yeah, absolutely. Okay, so you've gotten through the first 4 weeks. If you had a meniscus, then now you're starting to get off crutches and we're getting you walking, and all of a sudden you're like, hey, I'm 4 weeks post-op. I feel pretty dang good. Yeah. Like, what can I go do?
Walk.
Not a lot.
You can walk and get off the toilet.
Tensile strength-wise, 4 weeks is where your graft is statistically the weakest, which is this mean little game that your body plays, because that is when you actually start to
feel good.
Yeah.
And it kind of gets weaker until, 4 to 6 weeks, and then maybe get stronger again. I've actually heard studies that say 10 weeks.
You have to have that blood supply from your body grow into that graft, wherever that graft came from, whether it was your body or somebody else's body. Then the blood supply that was there dies off, and that your body has to grow new blood supply into that tissue.
Yes, and chances are when you say that you're a fast healer, that's not a real thing. So don't cheat the speed limits of recovery.
Right.
Age will increase it, but most of the guidelines are 18 to 25-year-olds. So if you're 40, don't feel like you should be on the normal guidelines. You might take a little longer to recover, and that's okay. Don't compare yourself to an 18-year-old.
Exactly. There is, I consider it like the strengthening or the heavy strength phase from 4 weeks to 8 weeks to 10 weeks to 12 weeks, where we're really trying to get strength in there. Yes, you do a lot of double limb activities, leg press, squats, deadlifts, trap bar deadlifts, things like that. We're also doing a lot of single leg to engage that single limb awareness, and this fancy term that we call proprioception, which is basically, does your body know where your knee is in space? Is your body controlling where your knee is in space? And those are little things where, again, there's 900 ways to skin a cat. Somebody might be able to have perfect balance when they're standing there and performing something like a single leg RDL because they're concentrating on the task. And the minute you give them a task for a distraction, then all of a sudden they're all over the place.
And I think the distractions and the multi-variable stuff that we do with people is important, because they can't focus on balance and strength and proprioception. You have to integrate that into a subconscious part of your brain.
Right.
If you have to think about it every time you do it, you're not going to be any good in sports, because you have to think about your sport that you're playing. It has to be automatic.
Right. And the opposite can be true, and you can use it to your advantage. I have some athletes that they have a really hard time, initially getting off crutches. And if you, like, soccer is the perfect example. If all of a sudden you say, hey, you know what, like, we're going to do a little, ball toss, or we're going to do a little activity where you're just, volleying the ball back to me, and all of a sudden that muscle memory kicks in, and they're not overthinking the balance portion of it, and all of a sudden you're like, look what you're doing, right? So you can use that to your advantage if you identify it, but at the same time, you have to identify some of those deficits early and figure out a way around it.
Yes, very important.
But it's, I would say the fun part of, well, there's fun parts throughout it, but some of the times when, patients getting off crutches, they're walking, and all of a sudden they're like, I still kind of walk with a limp, and you're kind of explaining to them, well, some of this is muscle memory, some of it subconsciously you're doing it, some of it is a weakness, some of it's range of motion, and then all of a sudden you start getting them to do more physical activities, like, hey, we're going to do a lunge, hey, we're going to do a trap bar deadlift. They're like, oh man, I didn't think that I could do that. And just starting to prove to them, hey, here are like the safe activities that you can do, but you can still do them.
Yeah, very important.
Yeah.
And then we go into the other phases where we get more into the plyometrics, where movement quality is super important. So strength alone doesn't do anything unless you know how to use it.
Right. So when you are pivoting, turning, jumping, making a reactionary movement, that is what, 4 to 8 times your body weight in terms of force that you're putting through that leg. So that's one of the reasons that we harp so much on training in terms of strength and quality of movement, is that if you aren't lifting weights, if you're not putting external weight through there, how else are you going to recreate that external force, or that 4 to 8 times more force through your body?
If you're doing an ACL rehab and you're only doing body weight exercises, somebody's doing you a huge disservice, because you will never return to sports in a great way unless you have to increase the loading beyond what your body weight can provide you.
Right.
Unless you're like 800 pounds, and then you're probably not going back to sports.
Probably not.
Probably not. I don't see a lot of sumo wrestlers, so.
But so going from there, then, as Mark touched on quality of movement, then we go into the plyometric phase, which I think I've had probably more patients cry the first time they jump and they run than first day of surgery, first day post-op. Yeah. Because to a lot of people, that is kind of the hallmark of.
It's scary. For them.
Getting back, right? Yeah. So running is essentially jumping from one leg to the other. So I personally do double limb impact before I do single limb. And I also will do a little bit of like partial weight bearing impact before I do full, but I like to integrate those two things in very, very quickly because mechanics speaking, you do things differently when you're not fully loaded, which is, as a side note, kind of my issue with the Ultra G treadmill.
Yeah, we could talk about the Ultra G for a whole episode.
But so I will introduce kind of what I call impact absorption. So basically pushing and landing. I will do that in a partial weight bearing initially so that people feel comfortable with it. But then again, like your mechanics are different when you're partial weight bearing and when you're weight bearing. So we're very quickly moving into that impact control and impact absorption, force production, and are they doing things the same on both sides of their body. Mark likes to say that we have mirrors in the clinic so that I can check my hair, but in reality, it's so that patients can see themselves.
And we can watch them.
Yeah.
When I introduce jumping, I will generally start the two-legged jumping onto a surface, just up. Step down, jump up, step down. And then I go from 2, land with 1. Then I do 1, land with 2, and then 1, land with 1. As long as they're all high quality over the weeks, sometimes months, then we start jumping down. I don't like to jump down until their quality is good going up.
Right.
And they're afraid to anyway. So building confidence with the jumping up is important because that's that explosive strength that we want. But the eccentric loading is extremely important, but definitely involves more muscle contraction and more strength. And so there's a confidence issue. And if I give a patient something that they're going to fail at, it'll destroy them in a way that's not really conducive to recovery.
Right.
I generally don't have people do things that I think they'll fail at unless I'm trying to teach them a lesson about being smarter on the weekend or something.
Well, and we touched base on this on the first part, but one of the factors that we can look at for return to sport testing or potentially identifying maybe some re-tear hallmarks maybe is decreased knee flexion with jumping. So essentially, do you try to land too stiff-legged, or do you allow your knee to bend so that your hamstring and your glutes and your quads and your calf and your anterior tib help to absorb the impact? Yeah. And having decreased knee flexion with landing compared to your contralateral limb or the uninjured limb. So basically, what is your bad leg, even though I hate saying that, doing compared to your good leg? Those are some of the things that we can identify. And so if you are sitting there saying, hey, great, I'm jumping and I'm running, but it looks like poo, trying to keep it G-rated.
Don't do it.
Then that's doing a disservice to the athlete, because not only is it in that moment where you're like, oh yeah, you're not doing it as well on that right leg as you are on your left leg and you get surgery on your right leg. That's going to have a trickle-down effect if you progress too quickly, or if you kind of push the envelope and you say, yes, okay, this is what you're doing, where, there's a huge difference between what the involved limb is doing compared to the non-involved limb. That trickles down, and you might think, okay, great, they're jumping, they're running, yeah, it's a little off, but no big deal. Well, guess what? At 6 months, at 7 months, at 8 months, it becomes a bigger deal, and now you're looking at an increased re-tear rate because of the one thing, versus being able to slow things down and saying, all right, yes, you can do it from a quantitative version. It's a C.O.R.E, you guys, don't worry. I didn't just flash everyone. It has to be a qualitative moment as well. You can't just say like, great, now we're at 10 weeks, now we're at 12 weeks, and you're jumping and it looks like poop. No. It has to look good too.
And when they're jumping like that, you will physically hear the difference. Yep. It's going to be louder and it's going to be a shorter absorption time. Mm-hmm. So we focus on symmetry. And another side note I like to bring up is rehabbing an ACL isn't just the surgical side. The other side has to work with it the whole time. So it's important, if your therapist isn't rehabbing both legs at the same time,
right.
Problem.
Right. Now, this is where, again, I kind of get a little ranty, but probably through the entire rehab process. But then once you start getting into really like the strength deficits, the movement deficits that exist, you really do have to lean heavily into those two, maybe three things. How did it tear? What is the athlete or the person going back to? And then what are the deficits that exist that you're identifying? And yes, obviously within the first 4 weeks, then it's not as evident, but as you get people into running, as you get people into jumping, as you get into the strengthening portion, and you start to say, okay, you know what, like you are going back to soccer. So yes, your running looks good when it's a planned straight line.
Yeah.
This is what we're doing. But you have to know that as you get closer to that return to play, that athlete's going to have to do a lot of reactionary things, has to do a lot of lateral movement and agility. You have to have them be able to do things with potentially contact, and all of those factors have to come into play. And that's where I think a lot of the inexperienced or unskilled PTs falter. And unfortunately, you don't necessarily, the patient doesn't necessarily know that they have an unskilled or an inexperienced PT because
nobody's going to advertise,
Right.
hey, I'm not really that good, but I want to get better.
Right.
Yeah, it's important to make sure that we look at the other limb too. I like to reiterate this. A lot of times injuries happen because of something. And sometimes that something is your right leg is weaker than your left, or there's a motion issue, or there's an asymmetry somewhere in the system. And then the contralateral side or the other side is injured because of that.
Right.
It's not always the fault of the limb involved. It could be a compensatory issue.
Right.
Often.
And that's a question
is.
sometimes that athletes and active individuals will ask when they're trying to get back into something, maybe pushing the envelope from a time perspective, and say, what's the worst that could happen? And very often the worst thing that could happen is not that you re-injure the same thing. It's that you cause another injury or
Somewhere
a different
else.
Injury somewhere else because of the compensatory effect.
Yes, big problem. So make sure that who is ever working with you is looking at the entire system all the time. It's not a knee rehab, it's a full body rehab. Unfortunately, that is very complicated.
Right. So going into probably the most fun, I would say, in the final stage of rehab.
Contact simulation. Claire likes to push grown men and women down on the ground and say, okay, get up again.
Yep. So I can do it again.
Close your eyes. You're not going to know where the impact's coming from.
But I get to do it.
Fall correctly.
Is the return to play aspect of it. And again, I cannot reiterate this part enough, is that you have to have every expectation and every knowledge about what that patient is going back to. I am a 5'1", very small female. I don't necessarily need to have played on the defensive line in football to be able to identify what is my patient going to need to do in order to get back there.
But you need to analyze.
Right, but you need to be able to
position.
analyze the position, what they're doing, what differs from, you can't just say, oh, football, okay, so you need to be able
Different positions need
to throw a
different
ball.
skill sets.
Exactly. And I touched on it earlier. There doesn't need to be a protocol that exists for all of it. If that's out of your element and you're a generalized PT that you're like, oh man, no, like I don't know how to do that, then pass them off to somebody who does.
Yeah, if you need a protocol to guide your rehab, that tells you something.
Right. And we touched on this in the beginning as well, but we are lucky and fortunate enough that we have patients that have found us because of kind of our expertise and our specialty in this realm. But it's also sad that sometimes those patients aren't sent to us. Well, very often they're not sent to us by their initial PT, by saying, like, I got them through the first 12 weeks and now I'm kind of out of my wheelhouse. Go see someone who specializes in it. That does happen, but it happens very rarely. More often than not, the vast majority of the time, it's the patient saying like, well, my PT said that I was done because I could run, or even if I couldn't run.
Or you go back to the surgeon's like, I don't like where you are. You need to find somebody better.
Right.
Go here.
And it's disheartening to think, and I try not to tell patients this to their face so bluntly, but I do try to make them aware, is that they are at a disservice in that aspect, because as we've tried to touch on here, as we talked through all the phases, it's not like you just magically snap your fingers and you're like, great, you're now at 12, at 14 weeks, and now we get to start doing sport-specific things.
It's criteria-based.
Exactly. You need to be doing all of these things with that expectation that you're going to return to sport throughout the very beginning. I can remember, total side note, and we're not even talking about knees with this, I had a patient that reached out to me and had said that she did have a PT and she was having shoulder surgery, and like at what point should she switch from her regular PT, regular quote-unquote PT, to a sport-specific PT? And I said, it was luckily it was email. So
Calm down.
yeah, luckily it was email, so I could write and pause and rethink and reword things. But I said that's a really, really hard question for me, because I put sports considerations into my patients from day one.
Correct. Always.
And it might be something as simple as, if somebody is working on balance, I might give them a ball, 7 days post-op so that they can do single leg balance while they're rolling the ball back to me. It might be a football player who is working on single leg balance, and I'm like, cool, great, we're going to toss the ball back and forth. Like just something to make them mentally aware of the fact that, hey, you're going back to sport.
Correct.
Right?
And the movement patterns,
Right.
muscle activation patterns are all very similar and important for the sport that you're in. So
Right.
they need to be specialized.
And so it's great when those patients find us and they say, hey, I want to be able to do more. But it just makes me a little sad because I'm like, man, you didn't just reach this threshold and think, okay, now I get to do this stuff. Like some of this stuff should have been happening.
It starts
before.
from day one, yeah.
It's very sad. It's very sad. But that is the fun part, definitely, where we introduce contact, we introduce falling. Everybody's going to fall. Everybody's going to have
Everybody's going to get fouled or
Yes.
run into. You have to get used to real sports, not just like the ideal setup
Right.
of simulating the sport. Simulate the contact. You
Right.
have to.
I have a very high level athlete right now that is post-op ACL, doing fantastic. I did her other ACL when she was in high school. Fantastic little athlete, hard worker, literally does anything that I ask her to do. But there is definitely the progression of, okay, well, we've done this and I've told you what we're doing and you know what that expectation is and you know what the movement's going to be. There's still a lag there between that and when we start putting her into practice, putting her into more reactionary and the unpredictability environment that is
Yes.
sports. And luckily, she's been through it with me before, and luckily she knows that there are things that can happen that she's not prepared for, and so she's all in. She's still like, yes, let's do this. I'm invested. Let's get through the crummy part. But I think very often there's that hard part of, especially at that 5-6 month mark, where you're like, hey, you're good, but you're not quite there yet.
Yeah.
And you have these athletes that are like, no, I'm good. Was
Yeah.
it Adrian Peterson basically like really screwed us over in that aspect.
Coming back at like 7-8 months or something
Yes.
stupid like that and had a record season. I'm like,
Right.
oh,
And you're like, ugh.
great.
But what people forget is that was his singular job at the
Plus,
time.
he's a genetic marvel, professional athlete, has the best surgeons, has the best PT, probably takes drugs. Like, there's a lot of factors that you don't understand. This is not a regular person, so don't compare yourself to people that aren't like you.
Right.
Please don't do that.
But as we know from research, is the biggest indicator of re-tear. We touched on like decreased knee flexion, all of these other things, is time since surgery, essentially. Letting that graft get stronger, having better control, having better proprioception, identifying movement patterns. Not only if Mark and I can look at a patient and be like, ooh, I don't like what you're doing, but can that patient look at it and be like, ooh, I totally
I can feel
see,
that, and
or
I can see
feel,
it,
or I can
yes.
hear, or I know that I'm doing X, Y, and Z, and that wasn't good.
I think that is a really good point. You have to get the patient involved. Did you feel what you did wrong there? No. Okay, I'm going to show you slow motion analysis. Let's do it again. Do you see it now? You have to see it and you have to feel it. Oh, that felt wrong. And
Yeah.
so when you say, how did you like that one? They're like, ooh, that wasn't good. That's what you want. You want that patient to be able to self-analyze their own movement because they feel it. And that's
Now-
hard. That takes time, especially if they're a little bit older or removed from sports or
Right.
they've never had to really analyze their biomechanics.
And I think one last thing that ties in really nicely what you just said is that there are some folks who choose not to rehab and not to have their ACL repaired.
Correct.
And there's always that question, and the same old thing is it depends, right? If my dad tore his ACL, then I would say, no, don't worry about it because you're probably going to have a total knee here in a couple of years. But there are people who choose not to. Now, I think statistically speaking, I have it here. Please hold.
It's pretty rare that I
The
would
risk of
recommend it.
developing osteoarthritis is higher in people who don't repair a torn ACL. Oh, I thought there was a statistic in there. Oh, 50% of people who have had an ACL injury or will have osteoarthritis within 10 to 17 years. So half of people, we did talk about that the first time we recorded this podcast that had
We
no
did.
sound, that if you don't have it repaired, then you are looking at an increased risk of osteoarthritis. I know there's kind of this trend right now, at least in PT. I don't think in the orthopedic surgeon realm, but there is, I think it started in the cash-based business, is that people were like, no, you don't need to have it repaired. Like your ACL is redundant and your ACL can scar down, which, as a side note, yes, there's a graft type or a surgery that is kind of trying to go that route, but that's an entirely different topic.
Yeah, totally
That's like a
different.
cutting edge sort of podcast. But for the most part, like the tried and true gold standard is to have your ACL reconstructed or repaired.
And you will still have an increased risk of osteoarthritis, even with the repair.
Right. So when
and they do a great job, but it's not exactly this. Nothing's ever the same exactly for 50 years.
Right. Right.
But it's good enough to play fantastic at sports.
Yeah. So when we sit there and we say, well, do you have to have it repaired? No, I mean, you don't have to do anything, but you have to look at a quality versus quantity sort of thing, is that you don't have time, right, to sit there and have surgery and put your life on hold for a couple weeks and all these things. But at the same time, pay me now, pay me later, right? Or do you have time to deal with a 50% increased risk of developing osteoarthritis 10 years later? If you are a 22-year-old and you're like, ugh, poor college student, I don't have time to do this. At 32 years old, are you really going to be like, yeah, cool.
My knee's trashed.
Right. So that does exist. And I think that, touching on what you said about what the patient can tell, hey, are you doing things differently from a surgical consideration? Sometimes you have to show them that if they're attempting to rehab from an ACL tear without the surgical consideration, is saying, hey, what you're doing now, is that really a compensatory pattern or a compensation that you are willing to do for the next 10 years?
Yes.
Yeah.
And without that ACL, you're going to have accessory motion if you slip. If you have a step off the curve that's awkward,
right?
There's no seatbelt,
right?
So every time that happens,
your meniscus,
yeah. So
or are you going to end up doing something weird where you have increased osteoarthritis not only at the knee but at your hip because you're doing something weird with that?
It's pretty rare that I would recommend somebody to not have it.
No, same. But unless there's some other consideration, like they're waiting for a knee replacement or something.
Yeah, or they're waiting for a better time. I understand that.
Yeah, but that was ranty.
It is very ranty, but it's very complicated, the rehab. And I see a lot of people who don't rehab it well because they may have gone someplace that they just dabble. And you can't dabble in things and be good at them.
Right.
So make sure you choose appropriately.
Right. And I think that's part of the reason that Mark and I are a little ranty about topics like this, is that we're very passionate about that. And we've seen patients come in and they're lucky enough to have found us and know that we have this, specialty, and that we have the knowledge and experience, and that we work with a lot of great surgeons, and they have this trust in us to be able to do these things, even maybe when they didn't start off that way. But it is definitely always in the back of my mind that I think, man, that this patient had a disservice from day one. Yeah. And that's unfortunate.
If you have a surgery and you go to a competent sports-related person in clinic, you should be stronger and better and more athletic leaving
and
rehab.
Faster and better looking and smarter.
Well, I can't do all those things, but I can do the physical things. You should be better coming out of it because you have somebody who's looking at your motion patterns that probably never was done before, and then involving you in the analysis of your biomechanical movement patterns.
Right. I think probably my ending note that I would like to say is that there's a lot of things that we can't control when it comes to injuries, right? I mean, there are genetics play a role, how you're anatomically built plays a role, what your life happens, right? Like people have to get back to work and those sorts of things. But there are a lot of things that we can control, and there's a lot of things that we can improve. So even if you are someone who's sitting there listening and you're like, man, I didn't pick Mark and Claire for my PT. What do I do about this? There's still hope for you. There are a lot of things that you can identify in saying, gosh, you know what? Like maybe you have knee pain because of something that doesn't have directly to do with your ACL. It's a compensation pattern. Maybe your balance is bad, or maybe your hamstring is still weak and you had a hamstring graft and you're relying too much on quads and you're having patellar tendon pain, or you're having patellar femoral compression. There are things that a really, really skilled PT can identify and not just chalk it up and be like, yeah, you had an ACL, like that sucks, man, your knee's going to hurt.
Maybe the other side of your ankle is a little bit lacking in, dorsiflexion, right, and that would cause the injury before, but nobody ever looked at that.
Right. And so if you are listening to this and you listen to us rant about how, oh yeah, you were put at a disservice, there's still time for you. There's still the ability for you to do something to rectify that situation. So call us. As always, you guys, if you have any questions, comments, concerns, compliments, please feel free to reach out to us. We are COREOmaha.com on the World Wide Web, Facebook, C.O.R.E Omaha and Sports Performance, Instagram, C.O.R.E Omaha, And the Twitter or the X exists, but don't tweet at us because that thing don't get checked. And we're not on TikTok because we're old.
Yep.
So if you have any questions, if you want to learn a little more about it, please feel free to reach out. Very responsive.
Yeah, we're going to have to do something a little lighter hearted next podcast.
We will. Yeah. We'll
a
get back to
little
our
more
lighthearted
fun.
ways.
Yeah, a little fun.
So reach out to us if you guys want more information or if you have a topic that you want us to talk about, let us know.
Yeah.
We'll give our opinions for free. I'm Claire.
I'm Mark.
We're out.
Out.